Hello, my name is Brandy Sellers-Hurst. This is an MSN evidence-based educational project scoping out colorectal cancer in adults with disabilities. This is the MSN evidence-based project to provide adults with disabilities the education and community resources needed to promote health and wellness and increase screenings to prevent colorectal cancer. The focus is a three-pronged approach for an educational plan designed for the patient, family, and community population. The goal of this project is to provide education on the importance of colorectal cancer screenings and increase the rate of colorectal cancer screenings in adults with disabilities in Carroll County, Georgia. This project was implemented at a local outpatient clinic in southwestern Georgia. The population of interest is adults with disabilities aged 18 and up. These individuals experience difficulty seeing, hearing, concentrating, and remembering, ambulating, dressing, and or bathing, as well as problems with activities of daily living, such as errands, groceries, and managing doctor's appointments. 16% of the world's population is considered disabled. 27% of adults in the United States have a form of disability. More than 13% of Georgians have a form of disability, as well as 13.8% of people in the southern United States. 15.2% of Carroll County is considered disabled. 1 in 4 adults with disabilities in the U.S. do not have a primary health care provider. 1 in 5 adults with disabilities in the U.S. do not receive routine health checkups within the last year. Colon cancer screenings are the most effective tool in reducing colorectal cancer mortality, and these screenings prevent between 25 and 50% of colon cancer-specific deaths worldwide. In 2001, 71.8% of all adults aged 50 to 75 received a colonoscopy screening in the U.S., compared to only 21.84% of people with disability. And adults with disability showed a markedly lower colorectal cancer screening participation rate than people without a disability. Blackman and Associates reviewed how U.S.-born African Americans have a lower rate of colon cancer screening than non-U.S.-born African Americans, and therefore they found that targeting education to this group can increase the rate of colon cancer screenings in U.S.-born African Americans. Ansa and Associates found that social support increases the adherence rate of recommended colonoscopy screenings more than any other variable, and social support can be family, friends, and members of a person's community that can assist them with their needs before, during, and after their procedures. By and Associates found that perception of impact affects adherence to colon cancer screenings in first-degree relatives of patients diagnosed with colorectal cancer. Education methods are important in the presentation of this information and to increase screenings, and they found that technology is not used to its full advantage. Making the POI understand how colon cancer will impact their lives, as well as the method this information is communicated, can impact screening rates. Stokes and Associates found that adults with intellectual developmental delays are less likely to receive preventative health screenings than adults without IDD, and that caregivers and families pose the greatest impact to health screenings for adults with IDD more so than any other variables. Therefore, education should be catered towards them. Patel and Associates reviewed the age of recommended screening and found that adults aged 45 to 50, the screening rate for adults has risen to 45 instead of 50 due to the increased rate of colon cancer diagnosis in adults younger than 50. The average screening rate is between 45 and 75, and for those individuals older than 75, that is determined by their health history and their doctor if they should continue or when to stop screenings. Several needs assessments were performed during this educational plan creation. One was the CDC Needs Assessment Tool that found that access to preventative care for the POI, transportation options, social supports, and lack of education on the importance of colorectal cancer existed. Gap analysis found that on average 60% of adults in the U.S. over 50 had had a colonoscopy screening in the last 10 years, whereas the goal or stated desire is that 100% of adults 45 and older will have had received a colonoscopy screening in the last 10 years. The identified gap, on average a 40% difference, exists in screening rates between adults with disabilities and without disabilities. And the knowledge, skill, and practice is the identified gap type, and many adults 50 plus have not been adequately educated on and do not understand the importance of colonoscopy screenings. Methods used to identify the gap were the statistical data in the National Cancer Institute Cancer Profile data on colorectal cancer screenings for 2017 to 2019. The SWOT analysis found that strengths were familiarity with doctors, caregivers, family members to assist with appointments and transportation, and insurance to assist with screening fees. Weaknesses were identified as access to providers familiar with working with disabled adults, difficulty educating on standards and need for preventative care for this group, and difficulty performing colonoscopy prep due to understanding of instructions and/or physical limitations with frequent restroom trips. Opportunities for improvement are more healthcare provider visits, giving opportunity to and exposure to educational material, community program attendance, providing educational opportunities, caregiver family involvement to improve education and adherence to screenings. And threats to improvement are caregiver and family decisions that screening is not appropriate due to the patient's health and mental status, patient fear of colonoscopy preparation and procedures, and fear of new doctors and unfamiliar procedures and preparations. The Windshield survey performed found that Tanner Medical Center is the major medical provider providing primary care, specialist, hospital, and urgent care services. There are multiple green spaces in the area, multiple gyms, different forms of housing, and community living homes for adults with disabilities, but it was found that there were no public transportation available. A family nurse practitioner in the area was interviewed, and she identified access to care, transportation, and addressing language and community barriers as her primary concerns for the area. And a nurse community member interview identified preventative health screenings as her primary concern. Theoretical framework. There were two theories that impacted this educational project. The first was nursing theorists Schuster and Gopinger and their nursing theory community care for public health. This guided the project by building a definition of community that encompasses shared characteristics beyond just geographical location and race. It also guided the educational plan to ensure the educational needs of this community were met more specifically than just identified by geographical location. Educational materials were created focusing on the educational needs of the POI in Carroll County specifically, including contact information for West Georgia Gastroenterology and pictures and non-written instructions to help supplement the verbal and written instructions. Social constructivism is considered a borrowed theory created by Lev Vygotsky, and it guided the project on the theory that learning is a collaborative endeavor and encourages building education at the current cognitive level with the knowledge that with education, understanding grows. Educational materials will meet the POI at their level of understanding instead of at a general level of understanding for the area, and will use multiple collaborations to build the most useful educational materials. Environmental, individual, and agent factors impacting CRCS. Environmental are food limitations and transportation issues. Agent are colorectal cancer screenings and the preparation for said screenings, and individual factors are comprehension of the need and the process and physical ability to perform it. Primary prevention in colorectal cancer screening is preventing disease in those without known disease or increased risk factors, such as scheduling screenings for individuals with only standard risk factors such as age 45 or greater, and educating patients and family caregivers on the screening process. Secondary prevention is preventing disease in those with increased risk factors like family history but no known disease. This could be for people who have first-degree relatives with known colon cancer or previous non-cancerous polyps removed. Tertiary prevention is preventing repeated disease or preventing disease advancement in those with known colorectal cancer and or precancerous polyp removal. So the educational plan was implemented at the local GI office, a local health fair, as well as materials were provided to local care homes to help patients not seen in these two locations. There was verbal, written, and visual materials used to present the education, and the education was provided to patients, family, caregivers, the community, and providers. On 3 community health diagnoses were identified. The priority community diagnosis for this project is ineffective communication between providers and adults with disabilities, as evidenced by decreased rates of colorectal cancer screenings in adults with disabilities in Carroll County, Georgia. The population intervention of focus is increase the rate of colonoscopy screening in the population of interest by educating patients, families, and the community on the importance of colorectal cancer screenings in the form of colonoscopy screening. The 5 roles of the APHN were used in this project as well. As the researcher, it was gathering the data used to create the education plan, including statistics on colorectal cancer and disability on the global, national, regional, and local area. The clinician is in the practice as a nurse, seeing the patients and identifying the patients within the POI, and he would identify from the education as the educator, implementing the education plan to the identified groups, and providing feedback and adjusting the education presentation as needed based on patient and caregiver feedback. As the collaborator consultant, working with providers and community leaders to create situations to provide the education. As the advocate, change agent is ensuring that providers and community leaders continue to implement the educational plan moving forward. Measurable outcomes were that participants can verbalize the purpose of colon cancer screening, name 2 things that can be found during a screening. They can explain the process of preparing for the screening and what to expect on the day of the procedure itself, and that they will choose to move forward and discuss their screening and their need for screening with their social supports and primary care provider. Finally, a measurable outcome would be that after presentation, a post-test would be administered where at least 80% of participants would score 85% or greater. Resources and budget were basically met. Handouts and home education materials was budgeted for $125 and came out at about $150, but healthcare materials and video creation were on par with estimated budget. And dates of implementation are ongoing or met, and with the determination that they should be met on time. Barriers to the project were provider willingness to participate in the educational plan implementation, as well as patient willingness to participate and or attend health fairs. As the project manager, barriers would be finding suitable locations for community education opportunities. Challenges during implementation are tailoring the educational content to a wide range of individuals with different disabilities, as well as the time and location to implement the educational plan. As mentioned before, during office visits, there is limited time. Again, these are our measurable outcomes, implementation and how they were met. Each thing was met by individuals at both the health fair and the office, recognizing the purpose of cancer agreeing to be screened, explaining the process back to the educator on how to prepare, what to expect on the day of the procedure, as well as at least 2 things that could be found during the screening. And several patients and community members agreed to discuss cancer screenings with their family. At the health fair was performed at a local church through Tanner Medical Center as the initial creator. There were approximately 25 participants, and they rotated through different stations, as well as we provided a large group presentation and provided opportunities for them to ask questions. At the end of the presentation, the participants played a memory game to review materials, and all of them scored greater than 90%. Implementation in the office was patient numbers ranged from 8 to 16 a day. While not all fell within the POI, all were educated using the educational plan as appropriate for their visit and history. The project showed that I have room to grow as MSN project manager to improve time management and communication with not only the preceptor, but also the practice educators themselves, focus on the education with adults with disabilities and their caregivers, but the providers in the area can benefit from more education on the different needs of the POI, and that's primary care providers as well as GI providers. The planning itself went well. I was able to come up with several good theory ideas, but implementing them into tangible products proved more difficult in some situations. And I overall think the project implementation would have been better suited to a primary care office or general health clinic rather than the GI office. The educational materials, the videos, written, verbal materials were used to appeal to multiple learning styles and to help improve understanding. And the patients and families that received the education stated that the different methods of education helped to close the gaps in their understanding. The education plan itself was well organized and implemented well, but could have had a larger impact on a different practical setting. Again, these are the objectives and how they were met. We discussed this already. Positive feedback was received from the preceptor and providers, and the implementation went well. Going forward, we could have improved with more community outreach. Going forward, I think that the presentation would be well suited to any location and expand the population of interest as well as the provider presentations. Everyone that I got feedback from provided feedback well, that it was well received, and Dr. Arler specifically stated that he would be implementing this project going forward to his patients. Here is a QR code if you want to look over resources and materials used for the creation of this project. Thank you for your time.